The BMJ Awards are to showcase and inspire excellence in healthcare. This is the story of how we took a problem that was important to pregnant women and their families. We undertook a journey with women and the patient support group to achieve an innovative step change in how we provide care for women with suspected pre-eclampsia. We took our new diagnostic test from bench to bedside, from campus to clinic, and improved outcomes for the women. This started local, went national, and has now changed international practice. In COVID times, this innovation has become more important than ever.
Lauren Ardron has first-hand experience of how devastating pre-eclampsia can be. Now a mum of 3, she's experienced it in all of her pregnancies, but lost her first baby at 26 weeks.
Baby Logan that we lost at 26 weeks due to pre-eclampsia.
Pre-eclampsia is a dangerous condition for both mother and baby. It is a leading cause of death in pregnancy throughout the world. In fact, every 6 minutes a woman dies from pre-eclampsia. Even in a country like the UK, about 10% of women will have suspected pre-eclampsia at some point. That means 70,000 women a year. 1,000 babies in the UK die from this condition. Yet, relatively simple measures save lives. If you know who's going to get pre-eclampsia, then identifying them and then arranging delivery in a timely fashion saves lives.
I look after women who have lost a baby from pre-eclampsia, and it's heartbreaking for them and it's tough for all of us in the health service. We know what a difference it would make if we could reach that diagnosis earlier, and if we could really see which women need that extra care so that we can help the women and hopefully help their babies too.
The exact cause of pre-eclampsia remains unclear, but a key pathophysiological feature is the development of an abnormal placenta. Instead of dilating to form large uteroplacental arteries as in normal pregnancy, in pre-eclampsia the uteroplacental arteries are fibrous and narrow, meaning that less blood reaches the placenta and the developing fetus. A poorly perfused placenta can lead to intrauterine growth restriction and even fetal death, and releases anti-angiogenic factors like sFlt1, which in turn reduces the production of pro-angiogenic proteins including PLGF and VEGF. Subsequent endothelial cell dysfunction and vasoconstriction coupled with salt retention in the kidneys leads to hypertension with increased risk of stroke and placental abruption. Local vasoconstriction reduces blood flow to the vital organs, including the kidneys, leading to proteinuria and oliguria, the brain leading to stroke, cerebral edema and seizures, and the liver leading to elevation of liver enzymes and right upper quadrant pain. Endothelial cell injury also leads to the formation of tiny blood clots in the microvasculature, which uses up platelets and damages red blood cells. Combined, these aspects form the basis of HELP syndrome, a complication that develops in 10 to 20% of severe pre-eclampsia and eclampsia. Lastly, damaged blood vessels become leaky, causing leakage of fluid into the tissues and peripheral and pulmonary edema. Previously, pre-eclampsia was diagnosed by measuring blood pressure and dipping the urine for protein, but these are relatively inaccurate and don't predict maternal and neonatal adverse outcomes. We worked with women in our PPI group and patient support charity Action on Pre-Eclampsia to better understand the impact of the disease. Vijya, who previously experienced pre-eclampsia, describes her own experience.
Pre-eclampsia took over my first pregnancy. I was very ill from the early stages. It was the most worrying time, the constant hospital appointments, scans, monitoring of the baby every week. Seeing the blood pressure readings increase as weeks of the pregnancy progressed, a time that is meant to be enjoyed turned into the most worrying time of my life, leaving us with uncertainty on when our baby would be delivered. Pre-eclampsia, the cause of losing our firstborn son, who was born sleeping. Pre-eclampsia is a terrible disease.
We have worked to develop a new blood test for suspected pre-eclampsia based on placental growth factor testing. We can take a blood sample from a woman in any setting and have a PLGF result within 15 minutes of the sample arriving in the lab. This result can then be used by doctors and midwives to guide surveillance for the woman, with a normal result meaning that a woman can continue with usual antenatal care, whilst a low or very low PLGF result indicates that surveillance should be increased to give the best outcomes for the woman and baby. We started with a case control study in which we showed lower placental growth factor concentrations in women with preeclampsia. Next, we did a multi-centre diagnostic test accuracy study in 7 maternity units in the UK, involving 625 women. We showed that PLGF outperformed all current blood tests for suspected preeclampsia and other markers of disease, and that the PLGF result allowed stratification for women most likely to need delivery for preeclampsia within 14 days, and those who continue pregnancy for many weeks. Then we did a randomised controlled trial in 11 maternity units in the UK involving 1,023 women. In the revealed PLGF testing group, the time taken to reach a preeclampsia diagnosis was halved and maternal complications reduced compared to usual care. When we looked at the costs involved, we found that clinical care that included PLGF testing cost less than standard practice, saving about £147 per patient because of fewer unnecessary outpatient attendances by the women.
What is the impact of PLGF-based testing on clinical care? It helps doctors and midwives identify the women who are at greatest risk of developing severe preeclampsia. It makes sure that the mums get the right care that they need, leading to better outcomes for mother and baby.
It's very important, very extremely important to families, especially if you've gone through what we've been through, if you've lost a baby or you've had a previous pregnancy that was really difficult through preeclampsia. At least you know you can go on to get an early diagnosis if it happens again and to get the best possible care.
New research suggests that a simple blood test...
And there's a new study published in The Lancet today that's found that a simple blood test can help make the diagnosis of a very common and potentially fatal pregnancy complication much easier.
Imagine you're 30 weeks pregnant and you develop symptoms of preeclampsia. Imagine if your healthcare professional isn't sure and admits you to hospital. You're still working, you have a busy home life. That hospital admission could wreak absolute chaos. Now imagine you don't have preeclampsia. Imagine the time that has been wasted. It's caused chaos and cost money. Now imagine a simple test that will rule out preeclampsia. Implementing this test saves the NHS £3 million per year. It prevents unnecessary admissions and uncertainty. It reduces maternal death and prematurity. As a result of this research, PLGF testing has been put on the Rapid Uptake programme. It saves lives.
So the evidence for the benefit of PLGF used in clinical practice is quite substantial. We now have many publications that are in high impact journals. We have proven that outcomes are improved when PLGF is used, and it saves money even when you take into account the cost of the test. Very few diagnostic tests adopted by the NHS have actually had trials proving efficacy and cost effectiveness. And we have achieved this with PLGF. This evidence has been incorporated into the 2019 NICE diagnostic guidelines for suspected preeclampsia and the management of hypertension in pregnancy. This means it can be accessed by clinicians and doctors easily. It's good to see that the Health Secretary has acknowledged this as a key component of safer maternity care.
This work has led to the development of a novel pathway for women with suspected preeclampsia who will now be offered a PLGF test, and the result will guide ongoing management. The test enables clinicians to determine the level of surveillance that each woman needs, meaning that interventions are appropriately offered to those at high risk, whilst low-risk women are reassured and prevented from making unnecessary trips to the hospital, particularly relevant during the ongoing pandemic. Not only does this result in safer maternity care and saves money, but it reduces the uncertainty and anxiety that Vijya and many other of the women we look after describe in relation to experiencing a pregnancy affected by preeclampsia. In a new study, Parrot 2, we are fine-tuning the process to establish whether there is added value in repeat testing at multiple points during pregnancy.
This film was made by Dr. Katy Kuhrt, a trainee obstetrician with a flair for using iMovie, who is interested in using PLGF testing in Uganda and Zambia, where we work in partnership with obstetricians. We put it together with the help of previous media coverage and support from our partners. We particularly thank Lauren, Vijya and Marcus for sharing what it means for women and their families. Thank you for listening.